What up, Ninja Nerds? In this video today, we are going to be talking about hyperaldosteronism. Before we get started, please help us and support us to continue to keep making free videos for you guys' educational enjoyment. How can you do that, you ask? Hit that like button, comment down in the comment section, and please subscribe. Also, you guys looking for some notes, some awesome illustrations to help follow along with me so you don't have to sit here and draw everything as we go along? Guess what? We got those, and you guys can check them out on our website. We have a link down in the description box below. Go check that out. I strongly urge, and I think it'll help you guys. But let's talk about hyperaldosteronism. So hyperaldosteronism is actually pretty simple, straightforward. You're making too much aldosterone. But then we get to ask the question, okay, where does aldosterone come from? What's the stimulator? What's the target organs? And all that kind of stuff. So first things first is, let's talk a little bit about the aldosterone pathway. So believe it or not, it's a very interesting type of pathway. You know, you have these special cells in your kidney. They're called juxtaglomerular cells. You guys ever heard of them? The JG cells, we call them. Okay, so the juxtaglomerular cells. They're present within the kidney, right around the afferent arterial. Well, what they do is they sense particularly the blood flow going into the kidneys. And so in three particular scenarios, one is when a patient has a low blood volume, that will stimulate the juxtaglomerular cells. When a patient has a low blood pressure, another way we can determine this is called an effective arterial blood volume. But I like just low blood pressure. I think it's an easier one. And the last one is a low renal perfusion. Maybe there's like some type of decreased blood flow going through the kidneys. Maybe it has nothing to do with the blood volume or the blood pressure. There's some kind of obstruction of blood flow. And so that would be another particular issue, is that there's some type of low renal perfusion, maybe due to an obstruction of blood flow, okay, as an example. In any of these three scenarios, if there's low blood volume, low blood pressure, or low renal perfusion because of an obstruction in the blood flow pathway, this will stimulate the JG cells. And the JG cells are so sensitive, man. They can't take a joke. And so what happens is, when that happens, they release renin. And so they start pumping out the production of this molecule called renin. Now, renin's interesting because there's a molecule here called angiotensinogen, which is made by our liver. It's kind of naturally circulating in our bloodstream. And what happens is renin's like, hi-ya! And it cuts angiotensinogen, and it cuts a piece off of it. When it cuts a piece off of it, it converts it into something called angiotensin 1. Now, angiotensin 1 is kind of cool because then what happens is angiotensin 1 circulates through the bloodstream, and it goes to your actual capillary endothelium in your lungs. And in the lungs, there's an enzyme called angiotensin converting enzyme. What the angiotensin converting enzyme does is it converts and cuts it, hi-yas, the angiotensin 1, and cuts a piece of it off and makes it into something called angiotensin 2. And then there's angiotensin 2 receptors that are present on the adrenal cortex. You know, the adrenal cortex, there's three different layers. You know this, right? So if I were to kind of take this here, we would have up towards the top layer, the zona glomerulosa. Then you would have these lines, which are the zona fasciculata. And then you would have this tissue right here, which is right around the adrenal medulla, the zona reticularis. So the zona fasciculata is the one that makes cortisol. We talked about that in Cushing's. But the zona glomerulosa is the one that actually makes aldosterone. And so what happens is angiotensin 2 will actually stimulate aldosterone production. It'll stimulate aldosterone production, and it'll be produced, and it'll go and exert its effects on multiple different areas of the body that we'll talk about in a second. But it's specifically at what point here? So you have the zona glomerulosa, the zona fasciculata, the zona reticularis. Which is the one that actually makes aldosterone? The zona glomerulosa. The zona fasciculata is cortisol. The zona reticularis is androgens, particularly for female sex hormones. So there's one stimulator. One of the stimulators, if you will, is the renin-angiotensin system. So that's a very potent stimulator of aldosterone production. And what really led to angiotensin 2 production? Low blood volume, low blood pressure, and a low renal perfusion because of an obstruction in blood flow. Okay. What's some other stimulators? Another stimulator of aldosterone production is electrolytes. Whenever two particular electrolytes that are present in the blood are abnormal, in other words, aldosterone, we'll talk about it a little bit later, but aldosterone helps to reabsorb sodium, to increase sodium, and it also helps to excrete potassium. So whenever sodium levels are particularly in a low amount, so whenever there's low sodium levels, this should be a stimulating factor. Maybe it'd be directly or indirectly, it'll stimulate aldosterone production because you're going to want to reabsorb more sodium and increase the sodium. And potassium that's really high, aldosterone helps to be able to excrete potassium. So it'll help to excrete the potassium as well. And so there tends to be three primary stimulators of aldosterone production. One is the renin-angiotensin system. The second one is low sodium. And the last one is high potassium. Now the question then comes, okay, aldosterone is in high levels. What is its target organs? What are its effects? That's what we need to go talk about. So what we're going to do is we're going to follow this aldosterone over here and see all of the different target organs and all the different ways that it can actually affect our body. Because that is really the question. Because we know the reason why someone would have hyperaldosteronism comes down to two particular reasons. One is their adrenal cortex is hyperfunctioning and it's saying, hey, I'm going to produce a lot of aldosterone. We'll talk about that. Or there's something that's activating the renin-angiotensin-aldosterone system that's causing there to be an increase in production of aldosterone. Those are the two primary reasons. So that's what I really want you to think about. The two primary reasons why someone would develop high aldosterone is due to increased adrenal function of some type, and there we'll talk about what this could be, or it could be due to an increase in the renin-angiotensin 2 activity. And we already talked about that, okay? Now, let's move over and talk about what kind of target organs does aldosterone work on and what's the effect. All right, my friends, so now aldosterone is in high levels, okay? So we got a lot of aldosterone just cooking in the blood for whatever reason. Maybe, again, it's due to the adrenal gland is hyperfunctioning, it's producing too much aldosterone. We'll talk about those reasons in a second. Or it's that the renin-angiotensin-aldosterone system is just way too active and it's pumping, lots of aldosterone. So you may ask the question, okay, Zach, could be the adrenal hyperfunctioning, could be high activity of the renin-angiotensin-aldosterone system, but what about hyponatremia and hyperkalemia? Not so much. They're not as much of a very profound trigger to produce a massive amount of aldosterone to have actual clinical pathophysiology. So the two primary reasons would be a very high renin-angiotensin-aldosterone system or hyperfunctioning of the adrenal cortex. All right, but either way, what does aldosterone do? Well, let's look at how it works in the kidneys. Let's actually look at its mechanism of action. So believe it or not, aldosterone, it's just like cortisol, it's a steroid hormone. So in other words, it doesn't have like extracellular receptors, it actually has like intracellular receptors that it binds to. So what it'll do is it'll bind on to these particular receptors and stimulate them. When it binds onto these receptors, it binds onto the receptors in the cells of the distal convoluted tubule. And what it does, it acts at two cells. This would be a principal cell, and this will be an intercalated cell. Okay, so if you want, I could write these down. This is called a principal cell, which is found in the distal convoluted tubule, and this is called an intercalated cell, and this is also found in the distal convoluted tubule. What does it do here? In the principal cell, it increases the activity of what's called the sodium-potassium ATP. So it pumps a lot of potassium into the cell and pumps a lot of sodium out of the cell. It also stimulates the activity of a sodium pump and a potassium kind of channel on the apical membrane. So then we pump more sodium into the cell and then more sodium out of the cell, and we excrete potassium out of the cell. So effectively, what you see here, the collective effect here that it has on the principal cells in the distal convoluted tubule, is that you will secrete potassium into the urine, right? Because it's going to push potassium into the cell and then out of the cell into the actual lumen to get peed out. So there'll be lots of potassium that's present in the urine. So what will that do to the actual potassium in the bloodstream? Well, technically, if you think about that, if there's lots of potassium that's present in the urine, then that means the amount of potassium that's actually present in the bloodstream, if I were to draw this here, so let's say that here's the bloodstream. Here's the bloodstream now. You're going to have less potassium present in the bloodstream, and you're going to have lots of sodium present in the bloodstream because we're taking sodium out of the kidney tubules into the cell, then out of the cell, and then into the blood. Okay, so that's the important concept to be able to understand. So you'll get something called hypernatremia and hypokalemia. Well, that's really, really important, okay? Now, one of the reasons why is let's talk a little bit about hypernatremia. So one of the problems with what's called hypernatremia hypernatremia, which is whenever the sodium levels are too high, is that this has a pretty profound effect on the pituitary gland, specifically ADH. And what will happen is it'll actually cause you to kind of produce a lot of ADH in the sense that ADH helps to reabsorb water across your kidneys, right? So that you get more water in your bloodstream. Usually when patients are hypernatremic, imagine just eating like a bag of like salty types of like chips or like nuts and things of that effect. It gets you really, your mouth gets like, oh my gosh, I must be having hypernatremia. Because what do you do as a response to eating all that salty food? You drink tons and tons of water. And so that could be the response. And so what happens is your body produces lots of ADH and that increases your thirst. Okay, and this is called polydipsia. Polydipsia. So this may be some of the effects that you could see. So again, one of the big ones is that you may see hypernatremia. The other effect is that from the hypernatremia, you may also see associated polydipsia, or increased thirst, to try to be able to get more water into your actual blood to dilute down your sodium. That's the whole goal, is to correct your hypernatremia. Okay, cool. So that's one effect. The other thing is the hypokalemia. What does that do? The hypokalemia is really interesting. So let's say over here, and we come down for a second, we talk about this point here. So this is hypokalemia, right? Hypokalemia is when you have this low potassium that's present within the blood. So if you have a patient with hypernatremia associating with it polydipsia, you may also have hypokalemia. What can the hypokalemia do? Well, whenever someone has extremely low potassium, what potassium does is, your pituitary gland is supposed to make something called ADH. Well, ADH is supposed to go and exert its effect on these particular receptors. These are called your vasopressin 2 receptors. So ADH should work on these particular receptors, and then what they should do is they should increase or stimulate the synthesis of these channels that are aquaporins. And what you should do is you should take water and move it out of the actual kidney tubules and into the blood, right? That should be the effect, is that you bring water out of the cells and then into the bloodstream. But whenever you have low potassium, what it does is it inhibits the ADH from being able to exert its effect at the V2 receptors. And so this is critical. You have to have very, very low potassium levels. But if there's severe hypokalemia, it can block the effect of ADH on the vasopressin 2 receptors. Now, you inhibit this effect. You no longer stimulate the aquaporin channels. You no longer reabsorb water into the actual bloodstream. And so instead, the water gets peed out excessively into the urine. And so what kind of effect could we see? We could see potentially a massive amount of water that gets lost into the urine. And so that could be another particular problem. And if you lose all this water, we actually call this polyuria. You know what this polyuria is due to? Is due to the low potassium blocking the ADH. This is a very specific type. This is actually referred to as nephrogenic diabetes insipidus. And so this is another potential effect that you could see with hyperaldosteronism. But it's really doing what? It's due to the hypokalemia suppressing the ADH effect at the vasopressin 2 receptors, inhibiting water reabsorption, losing it into the urine. So far, just within one action, we reabsorbed lots of sodium and caused hypernatremia. Hypernatremia can have an increase in ADH to make you thirsty, so that you bring more water in to dilute down your sodium. It can also cause critical hypokalemia. And the critical hypokalemia can block the effect of ADH at the vasopressin 2 receptors, prevent water reabsorption, and you lose massive amounts of water into the urine. Polyuria, massive amounts, like sometimes greater than like 2 to 3 liters within a day period. And this is called nephrogenic diabetes insipidus. Now, another concept here. Because sodium, hypernatremia, it's designed to help with retaining water. So if you think about it like this, let's say we have, for example, this hypernatremia. What it should do is it should help to increase water retention. So theoretically, hypernatremia should increase water retention. And if you increase water retention, theoretically you increase your blood volume. And if you increase your blood volume, you will theoretically increase your blood pressure, right? That's the hope. So the whole thing here is that you may see an increase in blood pressure. It's pretty simple. Imagine here's your kidneys, and what you're supposed to do is what aldosterone does is it reabsorbs lots of sodium. So I'm going to represent that with the black dots here in the bloodstream here. And if you have lots of sodium now in your bloodstream, what are you going to keep into the bloodstream now? I'm going to represent this with blue. You're going to keep lots of water into the bloodstream. And then you'll have more blood volume. If I return more blood to my heart, I increase my preload. If I increase preload, I increase stroke volume, I increase cardiac output, and I increase blood pressure. And so that's a really important thing to remember. You want to know why? Is because this increase in blood pressure, this is actually sometimes seen as secondary hypertension. It's a cause of secondary hypertension. In other words, this may be a patient who has high blood pressure that's refractory to multiple antihypertensives. What was the other disease that caused this? Cushing's. This is another big thing. I really can't stress this enough that this is sometimes one of the most common findings in combination with severe hypokalemia, hypernatremia. You may see some polydipsia, you may see some polyuria. It depends. The polyuria is dependent upon the severity of the hypokalemia, and the polydipsia is dependent upon the severity of the hypernatremia. But we're not done. Another interesting concept here is that these intercalated cells. Aldosterone, again, has receptors in the intercalated cells. When aldosterone binds onto these receptors, what it does is it stimulates these pumps. This is another pump. You know what this sucker is supposed to do? It's supposed to push potassium out and then reabsorb. I got to put another channel here. Bad boy, Zachary, you need another channel. Another channel here where it secretes protons, but at the same time reabsorbs bicarb into the bloodstream. So now I would get a lot of bicarb in the bloodstream, so my bicarb would potentially go up. My bicarb, I'm going to kind of write it like this. This would go up. I would have an increase in bicarb. But I'm secreting protons, and so I'm going to have a lot of protons present in my urine now. So what I effectively do then, if I were to bring this over here, I now do what to the protons in my bloodstream? Well, I'm actually excreting them. I'm losing them. So my protons will go down. But the other concept is that my bicarb, I'm going to be reabsorbing a lot of it. So my bicarb is going to go up. If bicarb goes up, that means you increase base. If you also lose protons, you lose acid. What is the overall effect here? Well, essentially, we know that pH is equal to what's specifically known, in the simple equation here, is the PCO2 divided by, the bicarb divided by the PCO2. The bicarb divided by the PCO2. This is that modified Henderson-Hasselbalch equation. So what we know is that if you decrease the bicarb, you decrease the pH. And in this particular situation, we call this metabolic. In this situation, we're increasing bicarb. Increasing bicarb. So you would also increase pH. So this is called a metabolic alkalosis. Metabolic alkalosis. So again, to recap, what are the overall features that we may see in a patient with hyperaldosteronism? You may see increased sodium reabsorption, increased potassium excretion. So you get more sodium in the bloodstream, hypernatremia. Sodium may be greater than 145. If it goes up, it may cause you to become more thirsty and drink more water. It also will cause you to excrete potassium into the urine, so your potassium levels in the blood will drop. If they drop down low enough, what could they potentially cause? They may block ADH from working at the vasopressin 2 receptors and cause you to lose water into your urine, polyuria. The other effect here is that hypernatremia also can hold water into the bloodstream. And so you have more water retention, blood volume goes up, you get more venous return, more preload, more stroke volume, more cardiac output, blood pressure should go up. and that can cause secondary hypertension, refractory to many antihypertensives. And lastly, you have an effect of aldosterone on the intercalated cells in the distal convoluted tubule. They secrete protons and reabsorb bicarb. So the amount of protons in your blood goes down, the amount of bicarb in your blood goes up. If we use this modified Henderson-Hasselbalch equation, as bicarb goes up, pH will also go up. And this is an alkalosis due to a primary metabolic problem, a metabolic alkalosis, my friends. So the question then comes, if you have a patient who has these particular features of hyperaldosteronism, what's it coming from? How do I know if it's coming from the adrenal cortex, and how do I know if it's coming from the increased renin-angiotensin-aldosterone system? Let's talk about that. All right, my friends, so the question then comes, we have a patient who's hypernatremic, hypokalemic, metabolic alkalosis, secondary hypertension, polydipsia, polyuria, the whole gambit. And we think that they have high aldosterone levels. We'll talk about how we diagnose this in a second, but the question then comes, okay, what's causing the hyperaldosteronism? Why is their aldosterone level so dang high? Because that's an important question when we get into the diagnostic workup. So, is it due to the adrenal cortex that's hyperfunctioning, or is it also could it be due to maybe a problem with the renin-angiotensin-aldosterone system? So let's talk about the secondary one. So the secondary hyperaldosteronism is really what I want you to think about is this is due to an increase in renin and an increase subsequently in angiotensin 2. That's the cause. So then you got to go back and say, okay, the reason why these were produced in high amounts was because of an obstruction of blood flow due to a low blood pressure or low effective arterial blood volume, or a true just hypovolemic state. That was the reason. And then you got to go ahead and say, okay, what would be a reason why there'd be an obstruction of blood flow that would then trigger these JG cells, here's my JG cells, to start pumping out renin? What's the reason for this? You know what the most common cause that you should know here is? This is called renal artery stenosis. By far, the most common cause of secondary hyperaldosteronism, renal artery stenosis. And it's simple, because they have high renin, this will lead to a high increase in angiotensin 2, and this will stimulate the adrenal cortex to start pumping out aldosterone. So when you think about these patients, if you were to look at their actual workup, their renin levels will be high and their aldosterone levels will be high. That's very, very important. Okay, for the next thing, what if it's a low blood pressure or low effective arterial volume? In other words, I'm just not perfusing this actual renal artery properly, and so the JG cells are sensing that there's just a not adequate cardiac output or blood pressure, and they're pumping out renin. And that is again increasing angiotensin 2. Let me fix this for a second. That's very ugly there. So increase in renin, increase in angiotensin 2, stimulate the adrenal cortex to start pumping out aldosterone. And then we see hypernatremia, hypokalemia, secondary hypertension, metabolic alkalosis, polyuria, polydipsia, which is dependent upon the degree of hypernatremia and degree of hypokalemia. So you see these things. But the question is why is there a low perfusion? And this could be many things. CHF, you have a poor cardiac output. Or cirrhosis can also cause a drop in cardiac output and low albumin levels. Or nephrotic syndrome, where you have low amounts of albumin and you can't keep an adequate amount of water in the blood. These all can lower your effective arterial blood volume and your blood pressure. What if you're just truly hypovolemic? So what if this patient in this particular scenario, their blood volume is just critically low, so their volume down. And if their volume down, they just don't have enough volume of blood to perfuse this kidney and tell the JG cells that there's an adequate blood volume. In this situation, if there's low blood volume, the JG cells will sense it. This is getting repetitive, I know. It'll tell them to make renin. Renin will increase angiotensin 2, stimulate the adrenal cortex to start pumping out aldosterone, baby. Now, the question is why are they hypovolemic? It's very simple. This could be GI losses. So in other words, they have vomiting. They're just, projectile vomiting, like exorcist level vomiting, or they got a punami because they have massive diarrhea, right? Or they're losing from renal. So it could be renal losses. One of the more common causes that you see a ton is diuretics. So these are things to think about. And so that's a really, really important thing to think about as a potential cause for a patient producing high levels of aldosterone. But the real key feature here is that they will have high renin levels and they will also have high aldosterone levels. Okay, that's really a big, big diagnostic clue. Okay, so we know it could be due to these causes. What would be the other ones? In other words, the adrenal gland is hyperfunctioning. Let's talk about that. All right, so the next situation is, okay, what if it's not due to increased renin? What if it's due to just the adrenal glands pumping out aldosterone for some particular reason? So in other words, what if there is a particular issue here where there's like a tumor or there's hyperplasia of the adrenal cortex, particularly of the zona glomerulosa? In that particular scenario, they would pump out massive amounts of aldosterone just from the hyperplastic tissue or from the carcinoma or adenoma, whatever it may be, but that's the particular cause. So the cause could be that they have, a adenoma. A very important kind of like helpful telltale sign is that adenomas are usually unilateral. In other words, they're only found on like one side. You don't usually see these affecting both kidneys. Whereas if it's hyperplasia, so you just have too much kind of like hyperplastic tissue, this is usually bilateral. I can't tell you how important this is when it comes to exam questions. They will kind of test you on this. So if it's a unilateral mass, it's likely an adenoma. If it's a bilateral thickening of the tissue, it could be hyperplasia. Generally, if a carcinoma is the least likely, these are really big. I mean, oftentimes like greater than 4 centimeters would be very concerning if I saw something like that. But the whole problem is that these suckers are pumping out high levels of aldosterone. Here's where it's interesting. When there's high levels of aldosterone, it exerts a negative feedback mechanism on the JG cells. So the JG cells, they normally will do what? They'll normally produce renin, which will try to cause angiotensin II production to occur, right? Well, guess what aldosterone does? High levels of aldosterone suppress the JG cells from releasing renin. And so then the renin levels will drop and the angiotensin II levels will drop. Why? That's the question, right? Well, the reason why they're going to drop is angiotensin II is supposed to stimulate aldosterone production. Aldosterone production is already too high. I don't need to have any more stimulation. So aldosterone suppresses further production of renin and angiotensin II because it doesn't need any more help making more of him, because these tumors or hyperplastic tissue are already doing that for us. Real quick thing for adenomas, whenever it's unilateral, we do give this a very specific name that sometimes can come up on your exam. We call it Conn syndrome. So just so you know that as well, Conn syndrome. But this is really, really important. So what I want you to take away from primary hyperaldosteronism, which is meaning a hyperfunctioning of the adrenal cortex, is that they will have low renin and low angiotensin II activity, but they will have high aldosterone activity. And that's a really important thing to think about. All right, my friends, last one, just as a quick little thing, it's kind of like a fun fact, you don't have to go crazy about this one, I just thought it was kind of interesting, is that you can actually have something called a pseudo hyperaldosteronism. Sometimes you can see this, and what happens is it has nothing to do with the JG cells, it has nothing to do with the kidneys. It's actually something, nothing to do with the adrenal cortex producing aldosterone. It's actually something very interesting. So there's 3 particular reasons if you want to know this. One is your adrenal cortex produces 2 particular hormones that act like aldosterone and have the same type of effects. In other words, they see effects such as what? The hypernatremia with the associated increase in blood volume and high blood pressure. They see polydipsia, hypokalemia, polyuria, metabolic alkalosis, etc. And what this can happen is it can be due to an increase in androgens because they may have a little bit of mineralocorticoid properties, or an increase in cortisol. So if you're producing lots of androgens or lots of cortisol, we call this congenital adrenal hyperplasia, and we call this Cushing's. So if you see Cushing's syndrome or congenital adrenal hyperplasia, these basically act like aldosterone, but they are not aldosterone. So in other words, if you were to check their aldosterone levels, it wouldn't be crazy high. That's what's really weird with this one. But it's because the androgens and the cortisol act like aldosterone. So because of that, they'll still produce hypernatremia. They'll still produce hypokalemia. They'll still produce high blood pressure. They'll still produce a low pH, like a metabolic alkalosis, etc. So you'll see all the similar effects. Another one is you're given some type of like, this is the weird one, it's licorice. So if you give them something like licorice, there's a particular chemical in the licorice. I don't remember exactly what it's called, but again, same concept. It acts just like aldosterone. And so it has the ability to have a mineralocorticoid property and produce all the similar effects that you would see as if aldosterone levels are high. That's why we call it pseudo-hyperaldosteronism. But because these have this kind of like weird aldosterone-like activity, they have the ability to suppress renin and angiotensin II production. So this will drop. So what's really weird about this disease is that you will have low renin and angiotensin II, but you will have also low aldosterone. Because it has nothing to do with the aldosterone, it's all to do with the patient producing other steroid hormones that act like aldosterone. Very weird, right? But that's called pseudo-hyperaldosteronism. Okay, so at this point, we've covered the pathophysiology and how high levels of aldosterone will produce the clinical features and complications that we can see in this disease. And then we also talked about what are the causes, the reasons why someone has high aldosterone levels or things that act like aldosterone and produce the same type of clinical effect and complications. Now we got to diagnose this. We have a patient coming in with refractory hypertension, hypokalemia, hypernatremia, metabolic alkalosis, polyuria, polydipsia, and we start running through some tests to figure out which one is it. Is it hyperaldosteronism? And if it is it primary or is it secondary? Let's talk about that. All right, my friends, so now we got to work up a patient who we think has hyperaldosteronism. So first thing we do is we check the aldosterone and renin, and we can actually use a ratio between them. So this is why I was kind of like spending so much time on the causes. I think this is going to be super helpful because we already kind of covered it a little bit. So let's say that I have a problem here where the JG cells are hyperactive and they're pumping out lots of renin, which is leading to lots of angiotensin II, which is causing lots of aldosterone. If you see this, where you have a high aldosterone and a high renin level, that right there might be enough to tell you that this is a secondary hyperaldosteronism. So this right here, if you see a high aldosterone and a high renin, this could be indicative of a secondary hyperaldosteronism. Secondary hyperaldosteronism, because they will have both a high aldosterone and a high renin. Now, the other concept here is when you do something, you can actually do a ratio. So you can actually form a ratio between these two, where you do what's called the aldosterone-renin ratio. And in this particular situation, what you'll notice is that the renin levels are going to be much higher. They have to be really, really high. And so the aldosterone-renin ratio tends to be on the lower end. We say like if you really want to be specific, like less than like 15 or less than 10, so 10 to 15 may be kind of indicative of, again, of a patient having secondary hyperaldosteronism. And so this would be those questions that you'd have to ask. What would be the reasons? You'd have to say, is it due to a low blood volume, such as in hypovolemia from GI or renal losses? Is it due to low blood pressure, so congestive heart failure, cirrhosis, nephrotic syndrome? Or is it due to an obstruction of flow, which is the most common cause, like renal artery stenosis? All right, it's pretty straightforward. All right, next one. We have a problem where now the issue here is that you have a adenoma or a carcinoma, or you have hyperplasia, and this is causing a massive increase in the aldosterone. So the aldosterone production is through the roof. And whenever aldosterone levels are in high amounts, what this does is, this actually does what to the JG cells? It suppresses the JG cells. So then the renin levels will drop. And then subsequently, the angiotensin II levels will drop. So then if you go ahead and look at this, if aldosterone's high and renin levels and angiotensin II levels are low, this is suggestive of a primary hyperaldosteronism. So a primary hyperaldosteronism. And so what you will see is you will see a high aldosterone, a low renin level, and the aldosterone-renin ratio will be very helpful as well. So the aldosterone is going to be high, the renin levels will be low, and then the aldosterone-renin ratio will be greater than, sometimes we'll say upwards of 40. So it'll be pretty high. Some will say 20, some will say 40, but it's usually just a pretty high. If you really wanted to look at it like this, if you wanted to make it simple for yourself, there'd be a decrease aldosterone-renin ratio and a high aldosterone-renin ratio for primary hyperaldosteronism. The numbers, they vary from textbook to textbook, source to source, institution to institution, so I don't want to get too crazy on focusing on numbers. Focus on understanding, and I think is the key thing. All right, and so again, this would be making you think, okay, there's something wrong with the adrenal gland. Is this an adenoma? Is this a hyperplasia? Or, my friends, is this some type of carcinoma? And we don't know that yet. We'd have to figure that out a little bit later, okay? The last particular situation here is that the zona reticularis, or the zona fasciculata, is pumping out things that are not related to aldosterone. So the aldosterone levels are actually kind of low, right? In this particular situation, they're not actually pumping out these very high aldosterone levels, but they are pumping out things like androgens, and they are pumping out things like cortisol, which have properties similar to mineralocorticoids. Or a patient is eating massive amounts of licorice. I know this seems crazy, but massive amounts of licorice, these have the ability to have similar aldosterone properties. So because of that, because they have similar aldosterone effects, but they're not actually aldosterone, what will this do then? If your aldosterone levels are theoretically high because of these, high cortisol, high androgens, or high amounts of licorice, this will do what to the JG cells? Suppress them. So renin levels will drop. Subsequently, angiotensin II levels will drop, and subsequently, aldosterone production will decrease, and that's why aldosterone production is on the lower end. Does that make sense? So in this particular situation, where someone has pseudo hyperaldosteronism, which means they don't really have high aldosterone levels, their aldosterone levels are low and their renin levels are low. We don't care about the ratio in these two particular situations. Once we see low aldosterone, we're like, oh, they don't have hyperaldosteronism. This is pseudo. So we don't even care about the aldosterone-renin ratio, okay? And so because of that, this right there would be enough information to say, is it something like, do they eat a lot of licorice? Do they have congenital adrenal hyperplasia? Or do they have Cushing's syndrome? And if you guys forget about Cushing's syndrome, go back and watch our video on Cushing's syndrome to go over all the different diagnostic tests. All right, my friends, once we've done this, we've then said, okay, I know if it's not real, if it's primary aldosteronism, or if it's secondary hyperaldosteronism. Now, for the next part of the tests, we really only want to focus on this one, because this is the scary one. These things oftentimes you can fix, with the exception of renal artery stenosis. We'll talk about that a little bit later. But the secondary one, the only one that I really kind of want to look into is renal artery stenosis, and I'll tell you about that because it's the most common. But we got to focus primarily on this one and figure out, is it an adenoma, hyperplasia, or carcinoma? So how do we do that? Let's talk about that next. All right, my friends, so we've gone through, we used the plasma aldosterone and the plasma renin, particularly the ratios, to tell if it's secondary or primary, okay? If the aldosterone-renin ratio is going to be high, that means that the aldosterone's high and the renin is low. That tells me it's from the adrenal. If the aldosterone-renin ratio is low, that means that the renin is high and the aldosterone is high, but not as high as compared to the renin, okay? So we use that ratio to determine which one it likely is. If the aldosterone-renin ratio is high and we think, okay, this is primary hyperaldosteronism, what we will do is we will confirm that this is truly the case. And so we'll do something called the salt suppression test. And I want you to kind of think about this as kind of a confirmatory test, if you will. It's just kind of adding some confidence to the diagnosis of aldosterone and renin, the ratios. So what we'll do is we will give the patient, we can do two things. One is we can give them IV sodium chloride, and we can give them a particular load of sodium chloride, or we can give them oral sodium chloride tablets and have them absorb it. So we can give them PO sodium chloride, like tablets. What we will do is once we administer the sodium chloride, whether it be oral or IV, we will then give the patient some time to respond to that. And what we can do is assess what will happen. So theoretically, if the sodium that you're giving them is going to increase in the bloodstream, this should cause hypernatremia, right? Now, what we know is that aldosterone is produced in response to the renin-angiotensin-aldosterone system or hyperfunctioning of the adrenal cortex, but we also said like one little tiny thing at the beginning. It could be from low sodium and high potassium. Well, that would increase aldosterone production. What if I wanted to suppress aldosterone production to see if I could suppress it? That means that this is not an adrenal cortex problem. It's not. It's likely something else. So, if I give them sodium, theoretically, in a normal person, this should act on the adrenal cortex and do what? It should tell the zona glomerulosa to then subsequently do what to the aldosterone? The aldosterone levels should drop. And if the aldosterone levels in the blood drop, or you know what else? Aldosterone is really interesting because it also can get filtered via the kidneys. So aldosterone can also be filtered via the kidneys. So there'll be aldosterone present within the urine. So there'll be low serum aldosterone or low urinary aldosterone. This would be a normal response. In a patient who has some type of adrenal process, that they have something going on with their adrenal cortex and it's hyperfunctioning, they won't give a crap about the high sodium. So in a patient who has true primary hyperaldosteronism, they will not be suppressed by the sodium loading. So what will happen in these patients is you will give them the sodium. The high sodium will not be able to suppress. Normally it should suppress aldosterone production, but it does not suppress aldosterone production. And so because it does not suppress aldosterone production, aldosterone levels will remain high. Even though this should inhibit it, it will remain high. And then if you're doing this via the PO sodium chloride, you usually test the urine. So you'll look at the urine aldosterone. And if the urine aldosterone is really high, if you're testing them via the sodium chloride tablets via the oral, the aldosterone level will be high. This is a positive test, okay, for there being a primary hyperaldosteronism. Or if you do this IV sodium chloride, then you're testing the blood. You're testing the serum aldosterone levels. And if the serum aldosterone levels are high, this is a test that shows that again, there has been no suppression of aldosterone. And if aldosterone is high, this tells me that there is no suppression, and this is definitely primary hyperaldosteronism. That is super important. So let me just quickly say this again. You check the plasma aldosterone and the renin. You look at those two. If aldosterone's really, really high and renin's also high, then that would make you think it's secondary. If the aldosterone level's really high, right, and the renin level's actually low, and you look at the ratio, then that ratio would be very high. That would make you think of primary hyperaldosteronism. How do I confirm that it's truly hyperaldosteronism, the primary type? I'll do the salt suppression test. In a normal human being, if you give them salt, it should suppress aldosterone production. So their serum and urinary aldosterone levels should drop, theoretically. If it's a person who has primary hyperaldosteronism, the salt will not be able to suppress the adrenal cortex from producing aldosterone. So it'll continue to be high, and their urine aldosterone and serum aldosterone levels, urine for PO sodium chloride test, and then serum aldosterone high for the IV sodium chloride test. It'll still be high. You won't be able to suppress them. That's a confirmatory test. So then what we do is we say, okay, the plasma aldosterone was super high, renin was low, aldosterone-renin ratio was high, confirmatory salt suppression test was positive, that it was actually showing that the patient does have hyperaldosteronism. Now we got to figure out, is this an adenoma, is this hyperplasia, or is this carcinoma? How do we do that? So what we do is we got to come down now and talk about the next step here. which is adrenal CT MRI and adrenal venous sampling. So when we do this, it's actually really cool. So let's say here that we have two particular scenarios. I only want you to remember this one. You have someone who has, adenoma, or you have someone that has hyperplasia, right? So let's say that what you do is you do an adrenal CT or MRI. And what this will do is this may find the masses. So the adrenal CT or the MRI, the adrenal CT/MRI, if you see bilateral lesions, that should point towards hyperplasia. So that'll point towards hyperplasia. If it shows you unilateral lesions, that should support a adenoma. You're probably like, why do I care? We cut out adenomas. We don't cut out hyperplastic tissue. We just suppress the hyperplastic tissue with drugs. Okay? So that's a really important thing. How can I extra double confirm this though? Because it's possible for adenomas to be bilateral. It's just rare. It's possible though. What we can do is we have the abdominal CT or MRI confirming that there's lesions. Then what we can do is we can test the blood. So let's say that I test the blood, and it looks at, what I do is I test their adrenal venous blood. So it looks at the blood draining from the adrenal system, and that's usually going to tell me their level of aldosterone. And this is actually really intelligent. Whoever came up with this is crazy intelligent. So what happens is you'll find the image that will show you the lesions. If the aldosterone levels that you sample from the venous system, so now, if the aldosterone levels is high bilaterally, it's hyperplasia, right? Because that tells you that the aldosterone coming from both of the adrenal veins, and both of them is high. That means it's definitely hyperplastic tissue. Whereas if there's high aldosterone only coming from one of the adrenal glands, this is likely an adenoma. Tell me that isn't cool. That's super cool. So this would be the ways that we would actually go about testing these patients to confirm which one it likely is. Usually carcinomas, those usually have a distinct feature to them based upon their kind of look, like if there's a lot of calcifications, if they're irregular, if they're greater than 4 centimeters, those are more suggestive of a carcinoma. But this is the things that you'll get tested on for your exam, so know this, okay? All right, so we've gone through, we confirmed, we started off with kind of our screening test, if you will. Do they have hyperaldosteronism, like primary or not? So you look at the aldosterone is super high, renin's low, aldosterone-renin ratio is high, that's primary. Confirm that it's primary with salt suppression test. Normally, in a patient, you give them salt that should suppress aldosterone production. And a primary hyperaldosteronism will not suppress them when their aldosterone levels in the urine for the PO sodium chloride test, or their serum aldosterone will still be high with the IV sodium chloride test. That confirms primary. Then you say, okay, which one of the primary hyperaldosteronism causes is it? Is it an adenoma, hyperplasia, or carcinoma? I do adrenal CT and MRI or MRI. That'll give me the qualities of it. Is it unilateral? Likely an adenoma. Is it bilateral? Likely hyperplasia. Test the adrenal venous blood and sample it. Is aldosterone high coming from both of the veins? It's bilateral, hyperplasia. If it's coming from only one of the adrenal cortexes, then it's likely unilateral adenoma. And if it's greater than 4 centimeters or regular calcifications, it could likely be carcinoma. These are the particular things that I want you to think about. Now, the last thing is, for that one patient population that has a high aldosterone, but an even higher renin level, so their aldosterone-renin ratio is low, so you suspect secondary hyperaldosteronism, which is one of those secondary hyperaldosteronism causes that you don't want to miss. It's the obstructive one, the renal artery stenosis. How do I do this test? How do I actually confirm that that's the cause? Let's talk about that for a quick second. All right, so with this being said, renal artery ultrasound is really helpful for that patient with the renal artery stenosis. And so what you can do is you can look at the ultrasound, and what it'll show you is it may show you like very high velocity blood flow as it's going through this portion here. So one of the things with the ultrasound is it may show you some high velocities that are running through this portion of the actual renal artery. But you can actually confirm, so if I really wanted to confirm that the patient has renal artery stenosis, you can do an angiogram where you shoot contrast into this actual artery and see that it doesn't fill as well. So there's like a filling defect, or that's like a very significant stenosis of blood flow there. That could be helpful as well. So this would just be one of those tests where if I had a patient that I did and it showed the aldosterone-renin ratio was low, and it also showed that their renin was super, super high, and it showed that their aldosterone level was high but not crazy high, then this would suggest a secondary hyperaldosteronism. And then what I would do is I would suggest, is it renal artery stenosis? Get an ultrasound. Do they have high velocities in a stenotic area? Confirm with an angiogram. That's an important thing to do. All right. Now, from this point forward, we are going to have to quickly talk about treatment. And guess what? There's not a lot to it. Let's talk about it. All right, my friends. So it's not too hard to understand the way that we actually treat this disease. In patients who have hyperaldosteronism, primary hyperaldosteronism, oftentimes, if you think about it, the problem comes from an adrenal process. So if this is some type of an adrenal process, it really comes down to the simplest treatment possible. If it's an adenoma or if it's a carcinoma, we desirably would want to do a adrenalectomy. Adrenalectomy. So where you cut the adrenal gland out. That's it. All right, that would be the desirable effect. Now, for hyperplasia, you do not do an adrenalectomy because it's bilateral. And you don't want to have to do that. You can try to suppress that effect. So what you can do is if they have hyperplasia, so if they have bilateral hyperplasia, we do not do an adrenalectomy. Do not do this. For the love of goodness, don't do an adrenalectomy, okay? You don't do this process. What you will do instead is that you will try to block the high aldosterone effect. So you'll just block the high aldosterone effect. So how do I do that? Well, whenever this actual adrenal cortex starts pumping out aldosterone, one of the effects that we know is that it can cause hypernatremia. We know that it can cause, from the hypernatremia, we know that it can cause an increase in sodium. So we know all the effects here is that you'll have an increase in sodium, and the increase in sodium can lead to an increase in water, which can increase blood volume, increase blood pressure. And this can lead to hypertension. It can also lead to hypokalemia, and it also can lead to a metabolic alkalosis. So these are the negative effects of this. So what I could do is to prevent them from having hypokalemia, hypernatremia with hypertension and low pH, is I could give them a drug that blocks the high effects of aldosterone. So what I'll do is I will inhibit aldosterone from being able to exert its effect. And the way that I would do that is I would give particular aldosterone antagonists. So I would give something called aldosterone antagonists. And there's two types here that I would focus on. One is called spironolactone, and the other one is called eplerenone. These two would have the ability to block the effect of aldosterone at the intracellular receptor site. So then you would inhibit the decrease in pH, you would inhibit the hypernatremia, inhibit hypertension, and inhibit hypokalemia. And this would be the way that we would treat this. So this is generally how we would treat bilateral hyperplasia, but we could also use this as a bridge. So you can use aldosterone antagonists not just only in hyperplasia, but this could be used as a bridge to an adrenalectomy. So that's another important thing, is that you can use this as a bridge to a adrenalectomy for a patient who has an adenoma or carcinoma. So if they have an adenoma, carcinoma, and you just don't have time right now to get an adrenalectomy for whatever reason, you can put them on aldosterone antagonists, and whenever they have time to get an adrenalectomy, then you'll do the adrenalectomy, and that'll be the definitive treatment. For bilateral hyperplasia, you do not do adrenalectomy, so you just continue to block the aldosterone for lifelong treatment, and you'll continue aldosterone antagonists indefinitely. My friends, in this video, we covered a lot of information about hyperaldosteronism. I hope it made sense. I hope that you guys enjoyed it, and as always, until next time.